Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for September 15th, 2021. Thank you for joining us this month. Our presenter today is Hadiya Green Guerrero. Dr. Green Guerrero is a senior practice specialist at the American Physical Therapy Association, or APTA. At APTA, her work covers scope of practice, the practice areas of sports, pediatrics, healthy aging, prevention, health promotion, wellness, primary care roles in physical therapy, nutrition, as well as health disparities and health and professional equities. She achieved her clinical doctorate in physical therapy from Washington University in St. Louis School of Medicine and is a board certified clinical specialist in sports physical therapy. Her clinical background has spanned New York City, Rochester, Minnesota, and Washington, D.C., including sports, orthopedics, early intervention, school-based, hospital-based, inpatient rehab, private practice, pain rehabilitation, and pediatric ICU settings. She also participated as a scholar at the National Institute on Minority Health and Health Disparities, Translational Health Disparities. She enjoys a history of volunteering with the Special Olympics of New York, Minnesota, and the District of Columbia as an instructor and sports director, and currently volunteers as a youth track and field coach in Washington, D.C. Dr. Green Guerrero's talk today is titled Racial Disparities Between Blacks and Whites in Social and Work-Related Arthritis-attributable Activity Limitations. Dr. Green Guerrero, welcome.
Thank you so much for having me this afternoon. I'm excited to be with you all, and I'd like to thank the Alliance for the opportunity to present, as well as my co-investigators, Drs. Malcolm Drury and Lauren Henderson. I have no financial disclosures or conflicts to report. And I'll begin with our vision statement at the American Physical Therapy Association for the profession of physical therapy as we move into the discussion about the arthritis-attributable limitations on social and work activities. And that is one of a vision of transforming society by optimizing movement to improve the human experience. And I really want us to keep that human experience at the forefront of our minds as we go through today's discussion. I'm going to start today by sharing a quote by David Ansel. And in this quote, he says, "We have political rights in this country and not human rights." And one might ask, well, Hadiya, what does that have to do with racial disparities and arthritis in today's discussion? And I really want us to take this example of the research that I'll share today on arthritis and the disparities that present themselves between Blacks and whites and between men and women as an example of a larger issue, which is human rights. We are currently in a state of a country that considers both housing and healthcare as privileges as opposed to human rights. Because if they were human rights, we'd all have them. And so that is going to become important as we discuss the results of our findings with the data that we looked at. So why study the burden of arthritis on work and social activities specifically? Well, we know, and I'm preaching to the choir, that arthritis is a leading cause of disability and has been described as one of the most pressing public health problems, at least of $140 billion cost in direct medical costs. It contributes, whether it's defined as a disability for the individual or a problem, as loss of time from work. It contributes to huge functional impairment. And as we know, there's direct links between pain and mental health. And when we consider mental health, in addition to the items that were just mentioned, we have a tripling of the rate of anxiety and depression that are seen in the presence of arthritis and chronic pain. You'll hear me use the term doctor-diagnosed arthritis. That means, in the context of today's talk, that a doctor has actually told a person that you have arthritis, not that they've said they themselves have Arthur, as it's affectionately known as. It is estimated that at least 22.7% of adults in the United States have reported having doctor diagnosed arthritis, right? Which is probably a large under representation of those who actually have it, because again, as I mentioned before, healthcare and housing, which I'll tie in again, are not equitably given to all in our country. For the purposes of the data that we looked at, arthritis disparities were looked at in the context of activity limitations. And what we know about disparities in terms of health disparities, that this is already known to be a notable issue in arthritis, specifically between Blacks and whites. So that part isn't new. But what is less explored is whether arthritis-attributable activity limitations between Blacks and whites and across genders vary based on their experiences with social and work-related activity limitations. When we use the terminology social-related activities in this case, arthritis pertains to joint or arthritis symptoms that interfered with normal social activities, such as going shopping, going to the movies, or going to religious or social gatherings. And what we know about lack of socialization, and this data is coming from 2017, so prior to the pandemic, and so was our extraction of the data from the CDC database and the BFRSS, that has been super highlighted since the COVID pandemic has hit us, and now everybody is more knowledgeable of it, that lack of socialization leads to isolation. And what we know about isolation, which is usually looked at in geriatrics, but it doesn't necessarily solely pertain to the geriatric population, is that it's an acceleration of premature death. The fact of the matter is we're social beings, and to have something like arthritis that is treatable or at least manageable not be addressed appropriately or show up differently in its experiences between groups of people, not based on a genetic factor, but other external factors, is an avoidable premature death and hence a health disparity. We also know that isolation leads to decline in mental health. And unfortunately, we also know that this also leads to an increase in the incidence of suicide. We also looked at work-related activities. So many people who are in jobs that are affected by arthritis happen to be in blue-collar lines of work, similar to what we saw in the COVID-19 pandemic first uprising. We saw people who were of groups of underrepresentation, minoritized, and marginalized groups. If you have arthritis to the extent that you're unable to do your job functions, that impacts your income and it impacts your family and presents itself with other insecurities like food insecurities and housing insecurities when one is unable to go to work or has to take off days from work. And if you're in a position that is an hourly position, you're not getting that income. You're not able to just take off sick time. So these two, although there were many questions asked on the survey that I'll go into detail a little bit more in the next slides, were really important areas to look at in a person's function based on an impairment or a condition that they have. Another professor that I'm highly in admiration of is Dr. Kamara Jones, who used to be the president of the Public Health Association. And she states that in this nation, we are ahistorical. And by that, she means we act as if we present, if the present, were disconnected from the past, and if the current distribution of advantage and disadvantage were just happenstance. So it's not by chance that when we go through the data that we're going to see these differences. There are things that have led up to where we are at in the state of our health and the state of our healthcare system that date back to even slavery and also the post-antebellum era, where Blacks were used to experiment on, where Blacks were considered to have higher tolerances of pain, and where we have residents even interviewed now that think that Blacks have thicker skin and have less pain. So the past is important to even those of us who practice in the field of health, because without knowing it, we are perpetuating a lot of the practices and belief systems that actually result in what is structural violence. Why talk about race? Because, as I mentioned, Blacks in the United States have faced systematic racism within the medical system, which includes non-consensual examination, experimentation, treatment, and access limitation. Gender is really important to look at because women literally tend to not be heard, not be believed, and or not taken seriously. So biological differences are usually framed negatively for women, in addition to them not being heard. And when women do represent or speak that they have pain, it's usually believed to be traumatized. So when we look at arthritis burden by race and gender, we pulled data, again, as I mentioned, from the 2017 CDC BRFS database. These are questionnaires that are done by phone, and these individuals are asked a battery of questions. Every state in the United States gets to choose what questions of this litany of questions they want to ask. We happen to choose items of data that were done in all of the 50 states. We looked at usual activities, we looked at work activities, and we also looked at social activities. And so the screens that I'll go through next will show us, well, what did people report? So this is self-reported data about the impact of arthritis on their usual activities. And so the short end of the stick is we found that Blacks were more impacted or reported having more limitations in their usual activities by race and gender, as well as women reported having more arthritis attributable limitations on their usual activities than whites and men, respectively. So when you cross the two together, what you see is what's graphed here. So white males are on the bottom of the screen, and as we go up from the bottom, white females are next, and then Black males and Black females. So the blue part represents those who have said, yes, arthritis impacts me or limits my usual activities. So white males, only 15% said, 45% said, yes, arthritis limits me and my usual activities, followed by white women at 50%, Black males at 51%, and Black females at 52%. So the difference between the white males and the Black females in usual activities and the burden of arthritis presents itself as a significant difference. When we looked at arthritis attributable limitations on work activity by race and gender, we see a similar pattern, but we start to see a greater difference, which was also represented when you only look at gender or you only look at race, and that white males and white females presented or reported limitations at 27 and 28% respectively, compared to their counterparts of Black males and females at 37 and 38%. So again, we see a significant difference between the races, not as big a separation between the genders when you combine race and gender. Social activities were asked in a way that the individual was asked, do you have arthritis attributable limitations on your social activities? Yes or no, a lot or a little, or not at all. So what you're looking at on this first graph is anyone who said yes in the blue, I have it a lot and or a little. So white males were reported at a rate of 37% that they were limited by their arthritis on their social activities. White females at 44%, followed by Black males at 51%. So we're seeing a 7% jump, and then a 58% in Black females. So interestingly, this stair pattern starts to really look significant, and actually even between each group as opposed to each race. And when we only look at the people who said arthritis impacted them a lot on their social activities, it's even greater, where white males are at 14% compared to Black females at 29%. So you see almost a 15% difference. Whereas the last screen, they were hovering around a stair step of 7 or so, or less. So what does all of this mean? Who has the actual heavier burden of arthritis when you're asking people their experience of being told by a doctor that they have arthritis and then functioning in the world in their work and social activities? What we found is that using a logistic regression analysis, that Blacks compared to white had a heavier burden of arthritis. Women compared to men reported a heavier burden, and Black women and men compared to whites had a heavier burden of arthritis on both their work and social activities. And for us, this meant that it really suggests that if we know that whites and Blacks are only actually at about a 2 to 3% difference in their prevalence of arthritis, you would expect similar outcomes or reports of their dysfunction or disability in their daily lives. But there clearly must be something external to the individual that's not genetic that we as clinicians really need to pay attention to. And so we see that there must be something that's either happening between the clinician and the patient as far as intervention and education on self-management. Either that's not happening adequately and or equitably to both Blacks and whites. And of course, the lived experience of being a Black person or a white person in the United States is different. So when you combine those two things, we do see that clinicians have a role in mitigating that disparity, and we can do so by education and intervention. Some of the things that we can do to change this disparity narrative, and I use the word narrative, right, because this is what a person is telling us when we're asking the patient, now that you know you have arthritis, and I'm asking you how it impacts you in your social and work activities, Blacks and women, and Black women especially, are saying that this is a huge burden on their lives, both in work and social, work-wise and socially. What can we do as clinicians Well, clinical assessments, for one, should be based on things that are not dependent solely on skin color or associated with race. So, for example, you might look at your electronic health records and see that your descriptor choices for pain or for the skin representation of abnormality are based on the skin changes that would happen to someone who has whiter or pink skin. So having a choice of only red or normal is limiting in the description and the interpretation of how the person presents. We as clinicians need to make sure we're using objective, if not standardized, screenings, and that includes mental health, social needs, and basic tenements. So are they sleeping? Are they getting food? Do they have stable or permanent housing? Though we might not be able to address each and every one of those as a clinician, we need to be locked in to having those people on our team who can help with those different areas of need, including the physicians, your physical therapists, your psychologists, and your social workers, to name just a few. What we also can do on an individual clinician level is do things like quality improvement projects. You can do periodic assessments of conditions or diagnoses. Look at the interventions and the outcomes across racial and ethnic and gender categories. You might find disparities where you didn't realize they exist even in your practice. And once you identify it, you can measure it. And once you measure it, you can address it. Continue to do things like patient satisfaction surveying. Is there anything else that you need? Is always a great question to ask your patient. I'll say it again, I really think it's important to employ people like social workers as part of in all settings of care, as part of a holistic approach to patient care. Implement interprofessional care at the prevention end of the continuum of care. As a healthcare system, we really need to stop waiting until someone is sick to care for them. It totally makes sense to have people like physical therapists in your primary care facility, psychologists in your primary care facility, for example, and social workers. And the evaluations of transplant qualifications is just an example, right? A lot of times you might not pick up on it initially, but the qualifications often are somewhat based on social circumstances. So does the patient have a mother who has depression? Was the patient recently named on a case but not arrested? And these things are used against the person and places them either lower on the totem pole of being listed or not being listed at all, as opposed to employing our other professional care team members to help us mitigate those things that look like they might be problems for a person to adhere to taking medications once they have the transplant so that they can be successful. I appreciate you spending the time with me today to quickly go through some of the data that we collected. And we hope that this, as the APTA says, works to building a community that advances the profession of not just physical therapy, but in our case, physical therapy to improve the health of society and us as colleagues in interprofessional care and not just multidisciplinary care. Thank you.
Thank you so much, Dr. Green Guerrero. That was really enlightening. And I was listening to the presentation and hearing the data and thinking, it's nice to have some of these updated statistics, but even more importantly, the way you framed it was such on a human level. It really helped me kind of envision the lived experience that people of color who have arthritis are experiencing. And that was really powerful. So thank you very much for your talk today. We do have time for a few questions. So those of you in the audience can type your questions in the chat box and I will read them aloud for discussion. I was wondering, Dr. Guerrero, if you had any recommendations of books or other references for healthcare professionals on racial disparities and what we can do to address these.
Thank you for the question. I highly recommend Medical Apartheid by Harriet Washington. Not just because it gives a good history lesson, but it really speaks to the different paradigms of health, including health policy, including health practice, and including community impact. Healthcare and Human Dignity by Frank McLennan is another good one. And Seeing Patients, as well as the book Overcoming by Dr. Augustus White, are two other great books that I'd highly recommend. Medical Apartheid, I actually think should be read by every single person who works in healthcare, because there are a lot of things that we are perpetuating as a healthcare body, including those of us who go into politics and health policy, that perpetuate the structural violence that is at the crux and foundation of our healthcare system. One of the things that I would point out in Medical Apartheid is that there actually is documentation of the census, and there was the physician actually predicted that African Americans would be extinct by the 20th century. So the data was actually manipulated that was gathered for the census, but it was used by a physician and given out to the government and the populace at large. So there's a lot of things that we don't readily keep at the forefront of our mind that conduct the behavior that we perpetuate today. And that's all of us. That's not just a white or black thing. That's all of us contributing.
Those are great. Thank you for those recommendations. And I think we'll take one more question here to keep us on time. This one is about worksite wellness professionals and maybe even employers. Where do you feel like wellness professionals, specifically those working in a worksite setting, fit into this conversation and how they work with different employees and their organizations?
I think they're instrumental in the preventative aspect of the continuum of care, and then also in the maintenance of well-being in the continuum of care. And that includes everyone from personal trainers, exercise physiologists, and then the assistance of each of the other licensed professionals. I actually think this has to be a team effort. It's the only way that you can get to the community. Each of us as healthcare practitioners are not going to touch each and every one. We know that everyone doesn't go to the doctor or to the therapist or take our recommendations. So the more hands on deck that are skilled or trained or certified, I think the better for us all.
That's an important point. And if you think about employees, they're going to be at work. And so if there is some kind of wellness component or some kind of physical therapist or other worksite wellness program, the individuals of color who may not be seeing their healthcare providers outside of work could have access to it through work. So that's a good point. We're going to go ahead and end the presentation there. Thank you so much, Dr. Green Guerrero, for your time and expertise today. We really appreciate the presentation. And I am going to launch a poll here for those of you still in the audience today, if you can respond to that before you leave. And just will make the announcement for the October 20th Lunch and Learn presentation, which will feature Kenneth Cameron, who will present the impact of osteoarthritis in military personnel and veterans. And you can look for the registration link in the email that I send out later this week when the recording is available. So thank you all very much for attending today, and that concludes our presentation.